All right, everyone, I have on Audrey Ross. She is a birth keeper and she educates on physiological birth and just really helps set people up for getting the birth experience that they are looking for through education. We all know that birth can be unpredictable, but so much of our choices that we make are guiding us through that and leading to different outcomes. So she is a huge advocate of helping people know what those options are and that they do have options so that they can feel safe and that they can potentially have the best birth experience possible. So I'm really excited to have her on the podcast. We're going to dive into some really fun topics. And so I'm really excited that you're here. So thank you for coming on.
Thank you for having me. I'm so happy to be here too. I could talk about anything birth related all day, so I'm down.
Yes. Oh my gosh, me too. Um, I will say though, because you're currently pregnant, when I was halfway through my pregnancy, I was already out of breath. Like you just sound like you're talking, like I feel like as soon as I pee on a stick and have like a positive pregnancy test, I'm like, when everybody like through my podcast interviewing people, I'm like, and you're just like, you
You
don't
know that.
sound like you're pregnant.
I'm an endurance runner, but I'm not currently running right now. But that is what I do. Like I run anywhere from 5Ks to ultra marathons through the
Okay.
mountains. So I probably do have pretty solid lungs. But
Yeah.
for me, I feel out of breath.
Yeah.
Like it's my own, I'm like percentage of out of breath. Yeah, I totally know what you're talking about. You can tell if a woman's pregnant even before she tells you just by her breathing. Yeah.
Oh my gosh. And I'm not good with my husband before I had kids was like, you don't know how to breathe. He's like, we'd be having a conversation and I'd be like talking, talking. He's like, what are you? I'm like, I don't know. I think being the youngest of four, I just had to like get things out while I could. So I would just, that's how I like learned to talk.
I do understand that. I was in a big family. I get that. Yep. Yep.
Yeah. Well, that's fun that you're a runner. I did a half marathon between after my second. So that was like a goal of mine to try to like
Yeah.
make me get back out there. And it was a
Mhm.
really fun experience. And also I'm really glad it's over. So
And that's my favorite distance. It's like long enough that I actually have time to like get into it and fully enjoy it,
yeah,
but it's cool enough that it's like no big deal. I love
no
half
big
marathon.
deal. Yeah, 13 miles, no big deal. It's nothing. I
Not
would never
now.
do a
If
full.
I could do it. Yeah.
Right,
I'm
right.
done. This season of my pregnancy, I've decided I'm 40. My body's not wanting to run. I will do other things. I can run the rest of my life. It's okay to
Yeah.
take some time off. Yeah.
Yeah, that's exciting. Well, tell us what exactly you do and how you got into this work. Like, what is a birth keeper, and what made you so passionate to create your platform and just spread all of the information that you do?
Well, I'll start just with my growing up a little bit because that kind of plays into it. I grew up with a mom who was a doula, but primarily in the hospital settings because there wasn't home birth really happening where I grew up. I grew up in Wyoming, and it's really very rare. I'm not sure what the licensing rules are, but there's not really midwives. So most of what she was doing was in the hospital, and so I grew up with these conversations around the table about birth trauma, about her attempting to advocate for these women, and time again, that was not working, and they were still having outcomes they didn't want. They were still having, interventions done that they didn't want. They were still having their babies taken. They were still being told things that were not true. And so these were like just the common conversation. So birth was just like that was the language we spoke. And I had an older sister who's a midwife as well. And so when I came into my journey of motherhood, I initially started, my plan was to have my baby at a birth center. And they dropped me at 36 weeks because my baby was breech. And that really left me scrambling with what to do. And my mom had had four breech babies. My sisters had breech babies, all of them vaginal. Like we knew breech was like just a normal thing, and our family seemed to do it a lot. And so I did end up going to the hospital, but I declined everything. I had my baby vaginally, but in a hospital setting, and I had to really fight. It was like war. I had to sign an AMA. They were not happy with me. I refused literally everything. Refused to put on their clothes. Refused the whole bit. But that's not an ideal situation. And no
Right.
woman have to be in war when she's in birth. And so my next birth, I was going to be at home, and I was working with midwives from a birth center, but they were going to come to my home. And they barely made it there. It was a precipitous labor. And once they were there, everything they did, I disliked.
Hmm.
And they everything was so perfect until they arrived. And I remember talking to my husband afterwards, and we were like they didn't do anything that we needed them to do, and I really disliked their presence there. And I can explain more of why later when we like as we talk through this. But that really set me on track to, and I had about 4 or 5 years in between my third and my second and my third, to really be diving into birth. And I had already started learning. I mean, I already knew a ton about it, just my upbringing, but really pursuing what does it look like to do birth outside of the system. I didn't like birth inside the system, and so I started pursuing what I do now, which is I am a birth keeper. And birth keeper, the word birth keeper, it's only come around because the word midwife is owned. So I can't say that I am a midwife because I don't have a license and I never will. And that is strictly by choice.
Mm-hmm.
So I am a traditional midwife or an
Mm-hmm.
authentic midwife. That's the correct terminology. But because that word is owned and there's legal issues around it, you can't say it unless you have a license attached to it, which is funny. It's silliness. So that's what the word birth keeper means. It's a traditional or an authentic midwife. So they are operating as a midwife, but outside of any licensing board. They are not owned or operated by the state,
Mm-hmm.
and they are not in cahoots with any hospital or medical authority. So that is what I do. And so I went on then to free birth my third baby, which was absolutely glorious and everything that I wanted it to be. And it just proved to me like this is so possible, and there is a better way to do birth.
Mm-hmm.
Whether you want support or whether you want to free birth. Now, if I had a me where I live, I would ask her to come to my birth, but I
Right.
don't have a me. And
Mm-hmm.
so I free birth. And that's what a lot of women do. And and I think that's a wonderful option, but I understand there is a deep need for women to have support, but the right kind of support is what
Yeah.
matters.
Right.
And so much support is actually very detrimental to birth, and it actually destroys physiological birth, which means it's one problem after another all the way through.
Mm-hmm. Right. Right. Uh, I love that. So where do you live? Are you like available for when I have baby number 4?
Yeah, oh, baby. I would love to travel. That is my hope. That's my goal. That's my prayer. Because there's so many women I talk to. I do birth trauma debriefs and I do birth coaching virtually, and so many women say like, "Could you be there for me?" And I'm like, "I would love to." So
Yeah.
down the road, I don't know how many year goal. Maybe I want to say 1 year. My husband's like, "No, it's going to take longer." But I would love to travel. But I'm in Oregon right now. There are some women who still want virtual support. They don't
Yeah.
have anybody there, but they want somebody who is on call, and they can call, they can FaceTime, they can Zoom if they want to, or they can just, pop on and say like, "Hey, I have a quick question about this."
Yeah.
And sometimes I'm just on standby in those virtual settings. And then I do serve women locally as well.
Mm-hmm. Yeah. That's awesome. I love that option because I mean, there is a huge rise in free birthing, and, for people listening, that's when people choose to birth with no one attending, and just birthing their own baby. And I actually interviewed somebody last year who had a free birth
Oh, awesome.
after a myomectomy diagnosis. So all of her providers were telling her that she had to have a C-section, and she just completely rejected it, did her own research, and she's like, there's like a 99% chance nothing's going to go wrong. So, which is
Yep.
like most
Good
birth,
for
right?
her. Yep.
So
That's cases in birth.
yeah, so she ended
Yeah.
up free birthing and had an amazing experience. So, um, and I know that that's not for everybody, and we're not really talking about free birth today, but I love that you have that virtual option, because like, even if somebody's like, you know what, I do want to do this outside the system, but it's nice to have somebody to be like, hey, this is what's going on. What do
Yeah.
you think? Especially if anything does arise, because right, we live in this just in case world, right? Of
No,
just in case,
totally.
just
Yep.
in case
Totally.
something happens,
Yep.
just in case, and that is what has been very detrimental, because we have a lot of low risk women going to high risk providers.
Yeah.
Um, and we're treated as such, right? Like, I'm 37. So, with my last 2 pregnancies, they're like, you're over 35. Like, we recommend these extra screening, these extra tests, that you take this over the counter drug, that you do all these things. When that everything's nuanced, right? Like 35 isn't this hard cutoff of
Not at
like,
all.
oh, all of a sudden you're a grandma. Like,
That's working. No,
right.
no.
Right. But that's how we're treated, right? Like even with
Yeah,
BMI,
totally.
like if your BMI is at this number, oh,
Oh,
there's this hard cutoff. Now you're
I
high
know.
risk. Like it's not, none of these things are individualized care.
Right.
So if for people listening, let's say maybe maybe they have birthed within the system and they're looking for maybe a different option. I'd
Mhm.
love to kind of talk about like the different midwives that there are, because there's midwives in the hospital, there's midwives at the birthing center, there's home birth midwives, like you said, traditional. And so like we know that people have better birthing outcomes in midwifery care. It's just a better model. It's been proven over and over. Um, and people might be like, oh, like if you're high risk, well, you can't go to them. And that's not necessarily true because your risk isn't, like I was just saying, like it's not just because of this certain thing. There's very few things that you actually need to be at a doctor for. And so people that may be in that high risk category can still birth with midwives and still have way better outcomes than in obstetric care. But there are
Mhm.
the different types of midwives. And so I work as a birth doula. And I know not all doulas are created equal, and it goes the same for midwives. I've
Totally.
heard of people who have had bad experiences, and that's so
Mhm.
sad because you're like, research shows this, and same with doulas. It's like research shows that like you're less likely to have a cesarean, you're more likely to have a satisfactory birth, and then you hear stories of things that they're like, well, I had a doula and they sucked, and you're like, I'm so sorry. That's not like how it's supposed to be. So for people listening, like what would be qualify them to birth with a midwife if they're looking for something different? And maybe what would be some things that they could ask or seek out if that's like a different route that they're wanting to go?
Yeah, really good questions. Yeah, not all midwives are created equal. The two biggest categories are licensed and unlicensed. And within the licensed midwives, you have CPMs. So they are, or CNM, sorry, certified nurse midwives. So they are trained as nurses and midwives, and they are working within the hospital setting. They're not working in homes. And so they're called midwives, but they're not. They're little OBs. They're not. They are completely trained in a medical model of birth. Then there's certified midwives, and then there's CPMs who are certified professional midwives. And those women are both trained for the hospital, but they also could be in a home setting. Actually, I think only CPMs are the ones who are in homes. I might have those wrong because I'm unlicensed. But um, the the main thing about the difference between a licensed somebody who's licensed and unlicensed is that licensing binds a midwife to the state, to her licensing board, which is most likely NARM, and often to a hospital that she has to stay in a good relationship with.
Mm-hmm.
And so that midwife will say no to things that somebody like myself would say there's absolutely no problem, because a license, it says she can only do this and this. So a licensed midwife, if you go past 42 weeks, they will drop you. If your baby is breech, they will drop you. If there is meconium, if your water breaks early and there's meconium in your water, they will drop you. If your water breaks and it's been open for 24 hours, often they will drop you.
Hmm.
If you're the list goes on. If you're often, like, blood pressure can be an issue, that they will drop you. Women who deal with things like cholestasis, or health conditions, they will drop them, or they will just say, "Oh, I can't take care of you." And so they have a lot. I mean, really, unless you're going to have a birth that's pretty much textbook, there's a good chance a licensed midwife at some point in your pregnancy will say, "I can no longer work with you."
Mm-hmm.
And there are also gems in that bunch, who will not do what their licensing board tells them to do. But my problem with that is that then they have to lie on their paperwork, and
Right, right.
they have to make it look that way. And so women will even talk about, like, oh, but she is an amazing midwife. Like, she doesn't act like a licensed midwife. And that's wonderful. But, like, for me, I really care about integrity. And it would matter to me to have to go and report and change the report, right? Like I couldn't sleep at
Right.
night if I
Mm-hmm.
had to do that. But there are some gyms in there who are really trying to serve women, and they are balancing those two things. But the vast majority that I have encountered, they still very much are doing a traditional, not traditional, a medical model of care. So then
Mm-hmm.
outside of that, traditional midwives, authentic midwives, birth keepers, they are trained in physiological birth. They are trained not about anything medical. I don't carry Pitocin. I can't. I'm not licensed to.
Yeah.
I'm not doing medical things, but I do know physiological birth very well. I do know what birth looks like. I do know what screws up birth. um I do know what normal, and by normal there's like no normal. But
Right.
I know that this is how vast birth can look, and that can be completely normal. And I do know how to trust birth, and I understand the right way to be with women and how to support them in that. And my main goal, literally, if I'm meeting with a woman and we're going through prenatal sessions, like I am over and over telling her, you don't need me. Like my whole goal is to empower her and teach her that she can do this by herself. This is actually what her body was created to do.
Mm-hmm.
And explaining that in depth so she feels so empowered to be doing this, that there isn't fear. I mean, we're constantly like bringing up like what's going through your head, what things you know, because we all have these things we kind of replay when we're, especially when we're pregnant. Oh, this could happen, this could happen. um but she doesn't need me. She may want me and I want to be there for her, but she doesn't need me. And I think that's the big difference in models of care, is there's still this perspective of like, you need a midwife because you need somebody to save you. Because what if
Right.
something goes wrong? And honestly, in birth, like the mother is the remedy, and undisturbed birth is the remedy. And when we don't mess it up, oh my goodness, birth is beautiful.
Yeah.
But the moment we tamper with it, you can just picture an animal. When you mess with their birth, mama may leave her babies for good.
Mm-hmm.
Things go wrong. Like we know when animals birthing, like you leave them alone, but then all of a sudden, within the medical world, we've decided nope, they need to be checked, they need to be prodded, they need to be poked, they need to be tracked, they need to be measured, and all these things, and all of those things actually destroy birth. And I mean, I can go into that in depth, how that
Right.
all
Right.
happens, but that's the bigger premise. And I think I probably got totally off track from the
No,
normal.
I love where this is going. Two things based off of what you said. Um, the first one I'm gonna forget. Oh yeah.
Okay.
Um, which we'll come back to.
The
So
postpartum.
you were saying like reasons why a midwife could potentially drop you.
Yeah.
So that's a conversation that to have. Like if you're learning this information, talk to your midwife because like that
Mhm.
is one of the reasons we chose not to birth at home this last time, which is a whole nother story. But um, because of some ways that my previous births have gone, like we made the decision to birth at the birthing center. The hospital that I would transfer to, if I did need something, I do not like. And I have doulaed there several times. And I know that I would also be treated like a alien for coming in past 42 weeks. And it would be a war. Like you said, it'd be coming into war, them being like, oh, well, since your baby's past 42 weeks, now we have to prick him every 4 hours and we have to do all these other things. Like, just all this stuff that like you're constantly fighting and you just had this baby and you're like, I want to go home. Leave me alone. Um, but it's conversations to have because it's like, well, what will drop me? And then what are my options? If I don't want to birth at home by myself, because I'm choosing to have a midwife there because that's going to help me feel safe in this setting. And like, what are the reasons you would drop me? What are,
Yes.
what if these situations arrive? What happens if I get to 42 weeks? What happens if I do develop high blood pressure at the end of pregnancy? What happens, X, Y, and Z. So those are
Are they free?
conversations to
Yeah.
have because those are conversations I also tell my clients to have like on their birth plan to talk to their provider about because most providers in a hospital are like, I'm not going to let you go past 40 weeks. So, you have to have these conversations to choose your right birthing team.
Even the wording, I'm not going to let you.
Right.
I mean, like, that is so against the way we should be viewing the relationship between somebody serving a woman in birth and the woman. Like,
Hmm. Right.
let me, but
Right.
you're right. That's exactly,
Right.
yeah.
Well, and then the second thing I was going to say is probably something that like will probably make a lot of people angry, or it's hard to wrap your mind around. Um, because the amount of stories that I've heard is if I wasn't at a hospital, my baby would have X, Y, and Z, or they saved me, they saved my baby. But what we have to face is that the hospital is creating the majority of these conditions. Because again, when you're birthing outside the system, you don't see these things arising. And now there is research coming out that's like, I
Yep.
mean, things that we've known for a long time, like the induction is causing issues.
Mhm.
Pitocin, it has a label on it that says do not use for induction, and
Yep.
yet is the most overused drug. It causes fetal distress. It can tire out your uterus. It can cause rupture. It can cause hemorrhage, and then you use it to stop hemorrhaging. And it's like, there's so much that it's like, that's everybody that I know who gets induced, they have Pitocin, and it's like, you have to read the label on this. That's like a conversation you have to have. This is not oxytocin. This is not what your body is producing. And so these things do affect your baby. Being in the system, inductions, even stress of a provider who's stressing you out and telling you, you have a big baby. And if you don't get
Yeah.
induced, your baby's going to die. Like those things play a toll on how your labor and your birth play out. And
Yep.
so many of the stories of, well, they saved my baby. It's like, but they put it at risk first.
Exactly. They caused it,
Right.
and then they came in as a savior.
And
It's
that's
exactly.
it's a hard pill to swallow though, because then you feel like it's your fault. And already as moms, like I'm dealing right now with like some oral tie issues with my baby. And then, he's having some gas stuff, and I'm already feeling like that's my fault, right? I'm like, man, like, is it this thing that I'm eating? Am I doing that? And this is my third kid. Like, and all my kids have had like oral tie releases, and we've had to do therapy and done everything, right? Cranial sacral therapy, chiropractic care, right? Doing everything. And then I'm like, well, did I do this one thing wrong? Was it because of the, like, and then coming to our births, even like I'm still processing my last birth. I'm still processing my first birth where my daughter ended up in the NICU for a week. And I'm like, I didn't get induced. I didn't, I did everything that I thought that I should, but then this thing happened. And it's like, well, was there something I did that caused that? So as moms, it's so hard to hear things when you don't want to, because we already beat ourselves up. But
So
we're also not educated on those things. And so that's like where it can be a hard thing to swallow. And it's not like you admitting like, oh, well, my kid has this issue because of me. That's like not what I'm saying.
no, not at all. And once we know better, we can make different choices. Like
Right.
most women could spend the rest of their lives beating themselves up about their first birth possibly or their second birth once they've learned differently.
Mm-hmm.
But there's no point in that. That is part of your journey. It goes with you. You have gleaned from it. There's nothing that can be done about that. But to stay in that place, I think that's the bigger problem. To be like, well, I'm just gonna like I'm not going to acknowledge some of the things that I could have corrected or that I might have said okay to that allowed this, or that I'm not going to acknowledge that the care provider actually didn't save my baby. They actually caused this problem. They should actually be paying the NICU bill. Like it was their fault.
Right.
Um, and those are really painful things to acknowledge, but how powerful to acknowledge them so that then we can grow and change. And with the next birth, we can make the changes we need to. And I
Mhm.
think it's so empowering to take that kind of responsibility. And also at the same time, it's like totally gut wrenching because we have to face it. And that's like not a comfortable place to be often. Um, but I think it's a really powerful place to be. And I think it makes women come out as like these bold mothers who are willing to take responsibility for both what has happened and then 100% for their births to come.
Mhm.
Um, and I mean, just an example, a birth I was just at recently, twins, the baby girl was born. She basically just, she fell out of mom almost. So she came out very quickly and she took a very long time to take her first breath.
Mhm.
And that's totally normal in that setting.
Yep.
There's no need for a baby to breathe right away. Her cord was pulsing.
Yep.
It was so plump and full and totally fine. And she was on mom and her eyes were open. But she definitely didn't have anything else going on in her body. She was white. And what happens in a medical setting, which is could be an OB, or could be midwives who are licensed and they know they have to do these things. What they do is they cut the cord,
Right.
resuscitate the baby. And now what
Right.
happens when they cut that cord is the baby is not actually ready to take a breath. Like for her, she came out so fast, she didn't really get the squeeze through the birth canal.
Yeah.
And so her lungs were still clearing. So there wasn't
Yeah.
actually space yet for her to take a breath. And when she could, she did. But if you cut that cord when there's not that ability to take a breath yet, a baby tries to take a breath because we all have this fight to live, and they end up um, inhaling, and then we're told that they have meconium aspiration. Well, they wouldn't have had meconium aspiration if we hadn't cut the cord and they didn't have to take that quick breath. And now
Mm-hmm.
we're trying to resuscitate them. And that's so much harder. And often that doesn't work. And I mean, on and on. And now, we've cut off this massive blood supply that they would have gotten.
Mm-hmm.
And now we have a baby that's a tiny baby, and we're trying to resuscitate them, and they don't have near enough blood in their body. And we have created this massive emergency, which is a true emergency at that point.
Yeah.
And if we had just stepped back, if we
Yeah.
had just let the mother and the baby bond without interference so that the oxytocin could flow, there's no shot of Pitocin in there, there's nothing like that, then everything happens as it should. But we're
Yeah.
not taught that. We're taught that babies should come out, crying right away, and we should fear all these things. And a lot of the learning is actually unlearning.
Right.
Unlearning, all these things we've been taught about, oh, this is something to be worried about. This is something to be worried about. And oh, it's actually not.
Mm-hmm.
And so that scenario is often caused, and babies end up in NICUs all the time.
Right.
Is they take a baby, they cut a cord to resuscitate instead of leaving a baby with a mom and giving it the time it needs to take the breath. And
Yeah.
the medical world doesn't know how to not interfere. And when you
Right.
interfere, adrenaline kicks in, and when adrenaline is present or Pitocin is present, both block oxytocin. And oxytocin is what does the work of a baby breathing. Oxytocin is what does the work of a woman's uterus clamping down so there's not excess bleeding. It's all oxytocin. But the moment we get Pitocin, oxytocin is blocked. And the moment we introduce fear, oxytocin is blocked. And so those scenarios are just created all the time in a medical setting.
Mm-hmm. So that's actually exactly what happened with my last birth. So it went very, very quickly, and he didn't get that final squeeze, and he came out stunned. And the midwife was like, he took a while to take his first breath. But we left the cord in place, and I had like asked about it, and she's like, he's still getting oxygen through the cord. Like, I ended up having a lotus birth. So he stayed attached until my placenta came out. And then afterwards, my husband cut the cord. But, and I was asking her, I was like, that's crazy then. Cause I know in the hospital in this situation where they come out like this, they would just cut the cord. She's like, you're literally cutting their oxygen supply.
Exactly right.
Like, you're cutting their oxygen supply. So then yes, you're creating this emergency. But since he was connected to the cord, he's still getting that.
Right.
And, some other things arose, but like, I was so grateful that that we had her knowledge there to do that, because I know that it would have been a much different situation in a different setting. And it's just, it's pretty interesting, like how you said, like just when you create these things, it's like how it makes sense. They're still getting oxygen through the cord, so you'd leave it attached. Like, why would you cut that?
Right.
I don't know. It just makes sense.
When you actually peel back the layers, it's like, oh my goodness, of course they're fine.
Right.
But we haven't been taught these things, and we
Yeah.
just think, oh, limp baby must be in distress. No, like they are trying to change from breathing amniotic fluid to oxygen. Like, this is a massive transition. Like, just give them a second.
Yeah.
And
They didn't get the
there's
memo that they're out in the world yet. They're like, wait.
no. And you even, again, like, I know I bring up animals, but like, you watch animals give birth, and like, it looks like they just flopped out some dead animal, and nobody like rushes in. They just both, the mom lays there dead, the baby lays there dead. They're both just like stunned by this thing that just happened. And then lo and behold, like, you see them both kind of start stirring, and they start to move towards each other. Like, that's so normal. That's the way
Mhm.
we were designed. And yet we act like it's like, no, like all these things have to happen right away. And that's actually that's what's causing the problems in many scenarios.
Yeah, that makes sense though with the like then they're trying to take a breath and kind of like inhale
Yeah.
because they don't have the
Yeah.
chance to like swallow maybe what's in their mouth.
Yeah.
Um
The lungs
so
haven't
yeah.
cleared. Yeah. Yeah.
Speaking of letting the cord pulse though, I was at a birth this last year where the nurse told my client that it's dangerous to let the cord pulse past a minute because the blood will go back to the placenta and the baby could get an infection and die. And I had
What?
never heard that before, but that's a thing that people, and I like looked at my client, I'm like, that's not true.
Oh my goodness. I mean, okay, but you realize these are the things women are told all the time. I just was
Right.
on a last week, and the woman told me that she was told that her placenta was tired. And
Yes.
I have never heard that one. That's stupidity. Um, but what had actually happened is they had given her so much Pitocin.
You're right. That does tire out your
Yeah,
placenta.
everything in your body is tired. You're not supposed to have it. It's not being,
Right.
yeah, that's, it shouldn't be used. Um, but I'm like, no, your placenta's not tired. Your placenta's been sabotaged.
Right. Right.
Like your whole body is just trying to survive this drug that you've given it. Um, but yeah, they will say what they need to to convince a woman of whatever they want to, and create this sense of trust, although it is very false because they don't actually know. And I feel like some of them just make things up. Like, did you make that up on the fly? Like, really? Like,
Yeah.
and also they have never been trained in physiological birth.
Right.
They
Right.
don't know. I mean, they just have no idea what birth actually looks like. And so they are trained that birth is a medical event and women need to be saved and it's unsafe. And so they are there to monitor and save.
Hmm.
And they don't understand that it's completely the opposite of that. It is a
Right.
biological event and it is completely safe
Hmm.
99% of the time when we just leave it alone.
I think it's really hard to get past that fear though, like
Hmm.
because it's the majority. There's very few. I think more people are, I think COVID changed a lot of people's minds and people started wanting to birth outside the system. One, because they were scared to give birth in the hospital, but then also being told like your partner can't be in there with you,
Yep.
or we might take your baby away if you're positive for COVID, or, just like so many things. And then people just started, you know,
Figure out another way.
looking in other directions. So I know that home birth is on a rise, even though it's still a super small percentage. But I think that the fear is so strong because even me being a birth worker and being a part of it, like I think that that's even something that like I deal with is
Yeah.
we do want a fourth baby and I would like to have a home birth, but I have not had an uneventful birth yet. So it's like, my first did end up in the NICU for a week for fluid in her lungs.
Oh, yeah.
Um, but I thought her cord pulsed until it was done. Um, I don't remember. They probably cut it at the 2-minute mark.
Yeah.
Um, and then my second, I had a significant hemorrhage and it was like on the point that I would have had to have transferred because I was at 1,000. Um, and I was at the birthing center that time and it was a beautiful birth. Like my second birth was like my ideal birth, like just
Can
glorious.
I ask you a question? Can I ask a
Yeah.
question? So they were weighing chuck pads.
I don't remember exactly how they were
Um,
counting it all.
that's what they were doing.
Oh, okay.
Um, so and looking at it.
Yeah.
How were you doing? How were you
Oh, I
doing?
felt great. I felt great. So that's like what I was saying to them too. I was like,
Okay.
I have zero symptoms. Like I'm not lightheaded. I'm not like anything. Like my blood pressure was great. Like everything was perfect.
Okay.
So
Can
I
we
wasn't
address it?
worried.
Can we talk about it?
Sure.
Okay. So, oh, I get so heated. I don't even know where to start.
So I ended
Um,
up getting a shot of Pitocin in my leg to
of
like
course,
slow it down. Yeah.
of course. Um, so how a woman feels is far more important than the blood you see coming out of a woman.
Yeah.
So some women can lose a little bit of blood and not feel well, and others can lose a ton of blood and feel fantastic, and they are fine. And every uterus in every single birth is going to clamp down and shut and close off all those blood vessels at a different rate because every birth is different and every placenta and where it's attached is it's all so variable. And often they're weighing chuck pads and they're looking at it visually, which let's just remember that like you have water coming out of you, you have blood coming out of you, you have meconium possibly coming out of you, you possibly even have your own poop and pee coming out of you. There's a lot of stuff coming out of you. So let's not act like this estimate of either visual or weighing is in any way accurate. How is the woman doing? Also, if your blood pressure is not dropping, you are not bleeding out. That is a hard, fast fact.
Mm-hmm.
You are not bleeding out. So that's like, is my blood pressure dropping? No, it's not. I'm fine. I am fine.
Mm-hmm.
So what do we need to do with a woman after she's given birth? Well, she needs to drink something. She
Yeah,
needs to eat
nourishment.
something. Let's balance her blood sugar. Even if she's not feeling well, let's get her lie down in a comfortable place and give her some time for her body. I mean, this is a big thing. Like I run a race, I'm dead. Like I feel like I'm dead afterwards. I'm not. I don't need to be rushed to the hospital, but like give me a moment. Let's give the mom a moment. Let's give the baby a moment because what actually causes the uterus clamp down is the oxytocin flowing, which means there's no fear in the room, right? The moment they've
Mm-hmm.
and they said you're bleeding too much, your oxytocin dropped because there was fear and it's blocked because now we have and so there's less oxytocin, which means less clamping down on the uterus. But we really just need it to be peaceful. We need your baby to latch. We need you to be skin to skin. We need to create an atmosphere of safety and nourishment for that mother, and then just watch as her bleeding subsides. But all the time, this is so common. I can't tell you how many trauma debriefs I've done where women would say, I was told I was hemorrhaging and I felt. If you are hemorrhaging, you will not feel fine. But at the same
Right.
time, you can often not feel fine just because of fear. So fear can do the same thing. Fear can make us lose our color and feel lightheaded and all these things. But guess what? Our blood pressure will be up because fear
Yeah.
does raise our blood.
Mm-hmm.
So if you are actually unwell and your blood pressure is dropping and we saw a massive amount of blood and all of these things were combined, it might be reason to act.
Mm-hmm.
9 times out of 10, like that's not the case if a birth has been undisturbed
Right.
because we've let the oxytocin do what it needs to do. And that's what your body was created to do. It wasn't like people just bled out,
Mm-hmm.
for all time before we had Pitocin.
Mm-hmm.
Um, yeah.
So this is
So,
also like questions though to like ask providers because
yeah,
I was at a birthing center, they have guidelines that they have to follow. So
yep,
it's not,
exactly.
wasn't like my midwife, she knew I felt great. She knew like whatever, but because of their relationship with the hospital that you have to transfer to because they are state licensed at 1,000, if they go over, they have to transfer you. So it's those
Yep.
are
So,
important things to take into consideration when you're choosing where to birth too.
yeah, should have either had to transfer you or say that it wasn't 1,000.
Right.
Yes.
Right.
So a big question to talk to your midwife about is about the third stage of labor. What happens after the baby comes out? When are you cutting the cord? Are you going to manually try to remove my placenta? Well, they shouldn't be, but they
Yeah.
will. They'll pull on the cord. They shouldn't pull on the cord. You can pull on the cord yourself, but nobody else should do that. Like what are you going to do with my bleeding? Do you carry Pitocin? Do you use Pitocin? When would you use Pitocin? Would you ever use Pitocin without asking me and me saying, yes, I want Pitocin, not just, I'm just going to give you this. That's not consent. Um, all of those questions, because actually so much can be wonderful. And then like the third stage of labor, third stage of birth hits and it's like, it all just can fall apart. And so a
Mm-hmm.
lot of these questions matter. And that could be a forgotten topic in prenatal sessions is like, okay, what's happening after this baby emerges?
Right.
We're just so focused on like getting the baby here. And so much sabotage can happen after a baby is born.
Mm-hmm. Right. Right. Yeah. I mean, we're talking about things that like most people wouldn't think to ask. And that
Yeah,
is why it's important, especially if you are looking to birth outside the system. I think most people are like, well, I have a midwife, so I'm fine. So even if
right.
you're birthing in the system, if you're like, okay, well, I'm choosing for midwifery care in the hospital this time. And in my experience, it has been better. Like one of the midwife groups here, I mean, they have a 75% VBAC rate, which is amazing because no other hospital around here or
Mhm.
practice does. There's actually one OB here who has a very high VBAC rate and a VBAC2 rate. But outside of that one guy who's like almost impossible to get into, this
Yeah.
midwife group does have a very high rate.
Yeah.
However, I've also seen, because of being under hospital policies and under guided things of, guidelines that they have to follow, a lot of unnecessary inductions because of blood pressure,
Yep.
hypertension developing, where they're like, okay, well, we gotta take you now, when it's like, you might actually have like some time. I
Yes.
don't know too much about the blood pressure thing. I know that it's tricky. And I know that like true preeclampsia is a real emergency, that you need to go. But the way that preeclampsia is kind of treated doesn't seem like a real emergency. So I'd love to touch on that.
Yeah. That's a huge one because it's this word that's so it we don't actually know what it means. Most women don't know what it means. It's just like this, oh no, you have preeclampsia word. And so there's this fear around it and like, oh, whoa, we don't even know what it means, but like it's this thing. And so actually preeclampsia just means that you have one or more signs that eclampsia could actually occur. Which eclampsia, there are seizures. It is blood pressure related, but it's a big deal, right? Like that's actually like you need to get right in and you need to have a C-section. It's a true emergency. If there's a true emergency, then it's time for a C-section, right? We're not going to mess around with induction. So, but the word preeclampsia is thrown around if women just have one high blood pressure reading, or they
Mm-hmm.
do urine test, so there's protein in the urine, neither of which mean that they have anything and could be totally normal. So you could have just been dehydrated that day. You could have just been stressed because you're getting your blood pressure taken in a doctor's office. Also, your blood pressure does go up towards the end of pregnancy, and that's totally
Yeah.
normal. There's so many little things that are like could have happened. You could have, I mean, it could have been literally anything that they could have given you a cervical check that you didn't want, and now they're taking your blood pressure afterwards, and of course your blood pressure's up. But they will tell women that they have preeclampsia based on these sole things, and then they will schedule their induction. Well,
Mm-hmm.
if you actually were at risk for eclampsia, the worst thing you could do would be induction, because induction raises your blood pressure. So if the goal is to not raise our blood pressure, we would never induce.
Mm-hmm.
So that doesn't make sense at all. Now if it's a true emergency, then let's get them right in and do a C-section. But it's not. They just want a reason to get women on their calendar. Because if women are scheduled for an induction, they're on the calendar. They can plan what doctors are going to need to be there, what nurses need to be there. The hospital flows like a machine. The hospital makes money. That's what it's designed to do. So they want that. So it's an easy sell to say you have high blood pressure. But what do you actually need to do? Well, you need to, first of all, go home and maybe take your blood pressure at home when you're
Yeah.
relaxed. You need to hydrate. You need tons of minerals. So start putting some sea salt in your water. You need lots of magnesium throughout your entire pregnancy. Like if there's one thing I could say, or two things, you need protein and you need magnesium. You need all the minerals. But like if I was only allowed to pick two, those are the ones I would choose. But you need magnesium. That's they're going to give you that in the hospital
Right.
for it. So like just start taking it at home. Um, you need, yeah, so you need to be taking tons of magnesium, and you need to start supporting your liver. So things like milk thistle can support your liver. Things like dandelion tea can support your liver. You could put on a castor oil pack over your liver. You could, like, all of these are such normal practices that we can go home and take care of ourselves holistically. And blood pressure just comes down when we
Yeah.
take care of ourselves. And so many women have, there's lots of time. So what they should say is like, oh, without fear, like we need to say all these things without fear. Like your blood pressure's, it's a little bit elevated today. So I just want you to go home and, take good care of yourself. You're going to take this much magnesium. You're going to drink plenty of water, add some sea salt to it. Like it could be so nonchalant, and women would feel so empowered to go home and take care of themselves instead of saying, you have preeclampsia. We need to schedule an induction. Well, their blood pressure will now probably be up until their induction because they are so stressed out about the fact they have this thing and they don't even understand it. And now their whole birth is screwed up because now they're supposed to have an induction. So it is just over diagnosed, and eclampsia itself is an actual thing and it is an emergency. But the rest, let's not treat it like it's an emergency yet, because it's not.
Mm-hmm. Yeah. Yeah. I mean, that's what I do see. Even at the birthing center, like their highest transfer out is hypertension,
Yeah,
you
it's
know,
silliness. It really is silliness. Oh, and
at
eat
the end
plenty
of
of protein.
pregnancy.
I already said protein. Yeah, all these things. Yes, they're just. It's really just like basic self care. I feel like, and it should be. This is what women should just be taught to do. Like this is the way you take care of yourself when you're pregnant, and and there isn't any of that. And then there's no support when women actually are struggling and like they don't know what to do. They're not, yeah, and usually they don't feel well. And if actually if your blood pressure was that high, you'd probably feel it too. Like
Right,
if it was
right.
always that high, you'd probably feel your head pulsing when you lay down on your pillow at night. You'd have a
Hmm.
headache. Your vision would be blurry. Like there are signs. So
Yeah.
yeah, it's just it's a word that's thrown around. And I think often because women don't fully know what it means and it sounds like a big word. And so it
Hmm.
creates fear. And so they can manipulate because fear is very manipulative.
Right. Well, I feel like the providers too, I mean, yes, induction is huge, but also, I mean, they're afraid.
They are.
They don't know, what if something does happen and then it's on them. So in there for provider, how like insurance coverage and malpractice and all that works, if they get the baby out and everything's fine, then it's off their hands. It doesn't
Yep.
matter what happens to mom later or what happens to baby later.
Yep.
So the induction is like their controlled environment,
Yep.
and then they can monitor and be like, oh, we need to intervene. And
Yeah.
then baby's out, mom's fine. They did their thing to try to save the baby versus expected management,
Yep.
like just letting things happen and then waiting, sitting
Mm.
on their hands and waiting for birth to
You can't.
happen.
You can't.
Right, right,
Yeah.
right.
I mean, what it means is that the decisions in your birth are being made for the good of the medical provider, the medical establishment, instead of the good of the woman. That's what
Hmm.
it means.
Yeah.
And so they will say what they need to say to make that occur. Because as
Hmm.
you said, they need the protection that they need. And so they will choose to do things a certain way because they want that protection. So it's actually not about the woman at all. It's
Yeah. But
about
I feel like most providers are like the way that it's even taught now, like they're not taught in medical school about physiological birth. They're not
not at
taught.
all.
So I think that they truly believe these things as well.
Oh,
So
I
I
agree.
don't I don't
Yes.
think most doctors are trying to like manipulate
No.
women, but I think that there definitely are some for sure that do. But I think that they genuinely are scared of what would happen if we wait. What happens if we wait past
Yeah.
41 weeks? What happens if I send you home with high blood pressure? What happened? Like they are scared because that's how they are taught to they're high, you're trained to be a high risk doctor, you're trained to be a surgeon, so that's what you look for, that's what you do, versus being a low risk provider, which the
Yeah.
majority of women are, so low risk.
They're not trained to sit with women. They're not.
Right.
They do not have any of that skill set whatsoever. They
Hmm.
are trained to be in action and to take care of things and yeah, they're
Which is
surgeons.
great when you need it, right? Like you
Yep.
said, in
Yep.
eclampsia and placenta previa, and like
Yeah.
reasons that you really genuinely need these things to
Yes.
happen. But I think that's also like another hard pill for women to swallow because, the C-sections happen 20% to 25% more than they need to in the United
Oh yeah.
States. So that's like
For
the
sure.
majority of them, right? Because
Oh
according
yeah.
to the World Health Organization, our C-section rate should be like 10%.
Yeah.
And we're
It's
at
like pushing,
32.
yeah, I was in some places it's pushing 40. Yeah.
Oh, yeah, in certain states and counties, and it's, yes, there's
That's
places that are
almost
like
half of the
50.
babies.
Right,
Yeah.
right,
I
yeah.
mean, that's insane. And then the
Hmm.
long-term effects of that are yeah, there's just ripple effects through from all of that. Mhm.
Right, right.
Yeah.
So, which is like an entire other podcast.
It is. It totally is. That's why I stopped.
Yeah, yeah.
There's no-
So I mean, even the research supports this, and that's like where it's hard because it seems like even like with the maternal death rates and just different things happening, it seems like other countries have figured it out that women need support, they need community, that even after birth. So they're having people come to your home to check up on you, to see how you're living, to see if you're nourished, to see what kind of care you're getting. And when you have midwifery care
Mhm.
outside of the hospital, that is what it looks like.
Exactly. You have
You don't just have a 6-week appointment.
right. Oh yeah.
So, and other countries have that. They're checking in, right? Because most of the deaths that are happening in the first, what do they consider maternal death? In the first, what, 45? No, it's more than that.
Oh my, it might be.
45 days after childbirth. I don't
think
remember.
yeah, I was actually gonna say 45 days too. It could be the first 3 months even though. It might
I
be
was
the
gonna say
first
it
three.
might be 90. Those were the two numbers that came to mind, but
Yeah, it might very well be 90. In fact, that actually sounds right to me because that's considered like the fourth trimester.
right.
So it probably is the 90.
Yeah. So that's usually when things are happening, right? And we don't have any support. So
Oh,
there's nobody telling you to eat protein and to take magnesium. There's nobody checking in on you and saying if you're okay. There's nobody educating your partner in signs to look for in
yeah.
you to make sure that you're okay. And it seems like all these other countries have figured this out and they have more midwifery care than we
Yeah.
do. And yet we're just failing in those areas. So it's tough because I feel like this conversation sometimes people get upset because it's like you're just bashing on doctors and you hate doctors and whatever. And you're like, well, but and
We
that's
can
not
come to
it.
my page. I'm far more offensive. So they don't
Yeah.
think
um, but I mean, there is, like I've shared a lot of stories on here about things I've asked in offices before or births that I've been at, and
Mhm.
it's not great. Like
Oh, we
I
have one of the
know,
worst fertility systems in the world.
right.
Yeah.
Yeah. Right. And even as a doula, like I got worn out, like just feeling like I'm going in fighting, like that I'm going in exhausted. Like it's hard attending births and just being like leaving and being like, what the actual F? Like, did this person just say, like,
Yep.
or like, even the stories that I'm constantly hearing from people of, I just had somebody share a story with me who you know, they knew that things were happening and they wanted to get checked. And the nurse was like, oh, I just checked you. You're not ready. Like, no, nothing's happening. And those stories like piss me off so
Yeah.
much
They're
because
not
I'm like,
to. Mm-mm.
right. And then they checked her and they're like, oh my God, we got to call your doctor right now. And he was 30 minutes away and this craziness. And I'm like, just listen. Oh my gosh. And so it's hard because the system has made us very scared. And so we continue to return to it, right? Like even when things go awry, because it's like, you helped me, you saved me, whatever. Um, and and so it can be very hard to get out of that. And there are, like I said, great doctors out here. There's like one OB here who has he's the only one in the area that allows women to vaginally birth after 2 C-sections. Like he's supportive of that. And unfortunately, he's probably going to retire soon.
Yeah.
But there's amazing providers who still deliver vaginal breech, and they might be your only option in some of those things. But before we wrap up, I do kind of want to talk about options because like that's the thing. So I know for us, like when we interviewed a home birth midwife here, our insurance wouldn't cover it and it's out of pocket. And that's also something that holds people back.
Totally.
Because our birth center is 100% covered. So like that can be when people are just like, oh, well, if you want something different, then choose something different. And that's not always an option for people. So I'd love to talk about that.
Well, so for people like for myself, I definitely am more affordable than a licensed midwife. Most birth keepers are. In fact, the goal is actually to keep the price lower.
Mhm.
Um, because I'm not taking insurance or anything, so it is out of pocket. But I know that also for unlicensed midwives, we're usually willing to work with women on payment plans, on swaps, on like
Mhm.
you got cows. Okay, yeah, I could use a freezer full of beef. I mean,
Right.
there's so many options because what it is it's a personal relationship with if you're doing this outside of the medical system, if you're doing it outside of licensing, it becomes a relationship. So it is a relationship of talking about like how does this work for the family, how are they able to financially or in some way support the woman who's coming to serve them. So there's just lots of conversations to be had there. And so I think those conversations need to be, I mean, it's worth asking, like if you don't feel like you can afford something, also like, did you ask? Did you ask if there's payment plans? Did you ask if there's other ways that you could swap services or something like that? Like, what have you asked for? And then also there is always free birth. And for some women, that's the right answer because it actually doesn't cost anything. Now, you might pay for some education. I do free birth coaching, so you might pay for a session of two of that if you wanted to, or you might not. You might choose to just get a book. You paid for a book, or you didn't do anything. And for some women, that's the right option. Um, but I think sometimes we just think that like it's either just the hospital or it's just some midwives and our insurance may or may not cover it. But I think there are there is more than like virtual support. There maybe it's not what you first thought it was going to be, but there are other options. Um yeah, I hope that
Mhm.
answers.
Yeah. Well, and I think another thing that we need to do is just really shift our thinking because, you know, we spend so much money on like our weddings and
Yeah.
on other things that we really, really want. You want to buy a Peloton, like that could be your birth, like so it is shifting our thinking. And again, like asking questions. Like most midwives I know, home birth ones do work out payment plans and different things like that. Um, and and I think that again, yeah, it is kind of taking that responsibility for our births, for ourselves, knowing like saving up for an expense. I mean, we really have to shift the entire system where things are like instead of certain things like things being covered, such as doula support, postpartum doula support, lactation services, like,
Yeah.
versus other things that are happening. It's like,
Oh, totally.
okay,
I mean,
like,
it's one of the most valuable things. If it is good and it is what you want and what you need, it's one of the most valuable things that you could both save for or be paying on because it well, for one thing, a birth that's undisturbed sets you up to have a breastfeeding journey that is
mhm,
successful. So
mhm,
like you want a successful breastfeeding journey, okay, what can you do to have a good birth? Um, so we forget like the cascade of all of these things. You don't want to have birth trauma. Okay, what can you do to stay out of an environment where you will have birth trauma? And even women who think that their insurance is like going to cover a lot of it, they come out of the hospital with massive, massive bills
right.
because of all the little things that they were nickel and dime for, and the baby that went to the NICU that they weren't expecting, and all of these other things that they weren't expecting. So it's not like families aren't still paying for birth. They are.
Yeah.
But sometimes when you say out of pocket, like there's this like, oh, I don't want to have to do that. I want insurance to pay first and then I'll get a bill from the hospital later. You're still
Mhm.
gonna you're still gonna pay for it.
Yeah.
Um and they are valuable services. They totally are.
Yeah.
They set women up for success, which means that there's less postpartum depression. So now we're not paying for all the things that happen with postpartum depression, where you need to go see, a therapist, or maybe you need to see a doctor and get some medication, like all these other things we pay for when we deal with the consequences of maybe not kind of putting our money where it needs to initially.
Yeah. And for people listening, because I know, I mean, epidurals, like, I can't even remember. It's like 60 to 80% of women get epidurals. I can't even remember. It's somewhere in there. Um, so a lot of people, this information, they're like, it doesn't matter. I'm going to go to the hospital and get an epidural. But what a lot of people don't know is like 15% of epidurals might not work, that there's different side effects, that there's so many other things that can happen with them. I had a friend who wanted an epidural, but her birth happened so fast that she didn't get one. And so it's like, what's your backup plan? Like, what are your other options? Maybe even research, like get educated on different, which I'll do a podcast episode on too, just like different forms of pain relief that aren't an epidural. What is that? So, because I mean, I think we're definitely speaking probably to like a percentage of the people listening here.
Totally.
But I think that this is very important information to get out there, and that if we want change, like we do have to be the change. We have to make different decisions, and it starts with conversations like this. So before we wrap up, let people know where they can find and follow you and learn more about what you do, um, and and anything else that maybe that you offer that we didn't talk about.
You can follow me on Instagram at A Joyful Birth, and that's my website as well. So you can find me there as well. And I offer coaching, I offer group calls, I offer a course called Mental Fortitude for Birth, which is really designed to create women a lot. Sorry, it's created to help women really prepare for the mental aspect of birth because we spend a lot of time talking about all the physical things, but birth is very mental. And I've learned that as an runner, especially and so I took a lot of the skills that I use in endurance running and applied them to how we work through birth because it's very mental. And if we think we can handle something, we can. And if we how we judge pain is based on how we think about it, whether we choose that it's pain or not. So
Right.
that's powerful. And then I also have a pregnancy journal there that a lot of women love and a few other resources. So yeah, you can find me there. You can find all my perspectives, which are very different to the medical world, but they might
Yeah.
enlighten you and shed some light on birth that you never knew, some perspectives that would make you think and yeah, be beneficial.
Awesome. And I'll include all of the links in the show notes, so it'll be really easy for everybody to find you. And I just want to thank you so much for your time and energy here today.
Thank you so much for having me. I loved being here.